Hello, good morning. Thank you so much for the invite, and definitely from the Quincy Board of Health for inviting me to speak today. My name is Sean Wason. Everyone always asks about the, how do you pronounce your last name? It's Wason. And I'm one of the newest faculty members in the Division of Urology at Beth Israel Deaconess Medical Center. I actually live in Canton, and they hired me to really build up the urology program at Milton Hospital. So Milton Hospital is my flagship hospital where I do surgery, but I also see and treat patients at Needham Hospital as well, and then Beth Israel downtown. So today I was going to talk on the evaluation and management of patients that we see with incontinence. And so there's a little bit of something for everyone. Just a little bit about me. I grew up in Toronto. I'm heading there over the Thanksgiving weekend. I'm Canadian, but I became a U.S. citizen about 4 or 5 years ago. My first foray into the United States was going to medical school at Howard University, which is in Washington, D.C. That was 2001, and had a wonderful experience there. And then I came up actually to New England, where I did residency at Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire. And I was there for about 4 years after doing 2 years of general surgery. And so the residency ended in 2011, and I found my way down south to, anyone know where this is? Norfolk, Virginia, where they have a medical school there, Eastern Virginia Medical School. And I was a fellow, and I wanted to do laparoscopy, robotic surgery, endourology. And so that was a year-long fellowship after residency training. And I loved the area. We were affiliated with a large urology group practice, Urology of Virginia. And it was just really the best of both worlds. We had the medical school, we had residents, fellows, and a very well-run private practice. My wife is actually from Norwood, and we had one child there, 2014, Leo. And she said, I'm not having a second kid in Virginia, we're moving back north. So at the tail end of 2016, we found our way back up here to actually Quincy. And we lived on Quarry Street, and we were close. And I was hired by Dick Babayan, who is one of my mentors and very well-known urologist in the area at Boston University. And so I was at Boston University for the last 5 years, where I sort of expanded the program for BPH therapy. And so I was there for 5 years, and then this opportunity in my community at Milton Hospital opened up, and I was recruited by Dr. Ariel Lumi, who's in the middle here, who's the chief of urology in the Division of Urology at Beth Israel. And we have a fantastic cohort of faculty members. Some of us are in Needham, most of us are downtown, and actually today we're running residency interviews. So these are medical students that want to go into urology, and after 4 years, and so we reviewed about 350 applications. We're interviewing about 50 of them for 2 spots. And so it's a very competitive urology residency. These are medical students that come from all over the U.S., just phenomenal credentials, and I'm fortunate that the future is bright and will be well taken care of down the road. So in terms of what I do, I treat a lot of patients with BPH. This is an enlarged prostate. I do all sort of modalities of therapy for gentlemen with large prostates. Kidney stones, so I see men and women both have large and small kidney stones. And at Milton Hospital, we're really working on a rapid pathway. So you come in with a stone, we can get you to the surgery, if need be, relatively quickly. And then I deal with prostate, kidney, bladder cancer, which is common in our population as we all get a little bit older. And then I try to do minimally invasive surgery as best as I can using the laparoscopy or the robotic platform. And then I do the cohort of general urology. So if you have blood in the urine, urinary tract infection, elevated PSA, I'll be sort of the first person that you see from your primary care providers. So my talk was just divided into 2. Really, the first part is looking at urinary incontinence, because I know this affects a lot of our patients that we deal with, men and women, and and we all know somebody that's sort of affected by urinary incontinence. So, how common is incontinence? What are the different types? How do we evaluate? And then, obviously, you want to know, how do we treat urinary incontinence? The second part, for some of the men in the audience, I'm going to go over, if we have some time, benign prostatic hyperplasia. What are some of the newer modalities to treat men with an enlarged prostate? So what is urinary incontinence? It's really the involuntary loss of urine in socially unacceptable situations that's bothersome. And I think the key thing is you really have to be bothered. There's some patients that have incontinence, they're not so bothered, but the International Continence Society says that really you must have bother from the urinary incontinence. And so it's very common. It really impacts quality of life, and I think what's important to know is that it's treatable. We have a lot of different options for men and women with urinary incontinence. And this was one survey that was given out to a cohort of patients, and it was really interesting in that bowel and bladder incontinence was viewed at as a fate worse than death for a lot of the patients. And so, it can be very bothersome, significant. It can affect quality of life, and it could make someone maybe not leave the house, end up with depression. And so it's something that we take very seriously, and we do our very best to make an accurate diagnosis and then give you certain treatment options that are well within your goals of care. There's multiple types of incontinence, so I'll usually see urinary incontinence, and then really what we have to do as urologists is be a little bit investigators. We have to figure out, okay, well, what type of incontinence is it? Is it stress incontinence? Is it urge incontinence? And then, or could this be a mixture of different types of incontinence? So that's really our role as the urologist, to really narrowly define the type of incontinence, how bothered are you, what have you tried, and how can we treat you moving forward. And throughout the talk, feel free, you have a question, just raise your hand. I'm happy to answer any questions. It's very prevalent. So 25 million Americans here in the US are affected by urinary incontinence, 200 million adults worldwide. The majority are women that are affected by urinary incontinence, but there is a significant amount of men that are also affected by urinary incontinence. You may have had prostate surgery and you can develop urinary incontinence. And this statistic, more than 50% of women in nursing homes suffer from urinary incontinence. So if you're out there, you're not alone. In the community, 17% of older men, up to 30% of older women. And we see this quite a bit in the hospital as well. And some patients have not sought medical care for a while, but they end up in the hospital, and then we sometimes get consulted for urinary incontinence. So it's stigmatizing, and it's prevalent across the lifespan. So if you look at the graph down here, this goes from sort of young to old, and as you get a little bit older, this is sort of the prevalence of urinary incontinence. And so urgency, mixed incontinence, stress incontinence, all these patients, over the age of 70, will have urinary incontinence. So significant problem. And when you compare it to the other chronic diseases that we do see, hypertension, so high blood pressure, depression, diabetes, there's a significant amount of patients that will have this problem. What are some of the risk factors? As you get a little bit older, your bladder's likely to undergo some changes. And so if you weigh more than what you should, so obesity, high blood pressure, diabetes certainly can lead to urinary incontinence, and then dementia, depression, and the decline in mobility. And urinary incontinence does increase the risk of falls in the elderly, anxiety and depression. So, you have a lot of urgency, you're trying to get to the bathroom quickly, it's the middle of the night, it's dark, you may, fall or trip, and it does put you at significant risk of falls. And, we know it significantly impacts quality of life, can really change your mood, depression, anxiety, social isolation, You may not want to leave the house if if you're worried about how your leaking is thought of by your friends or family. Financially burdensome, how much do pads cost, safety pads, undergarments, that's an added cost to our patients. It can lead to other associated things that we see in the elderly, hip fractures, leg fractures, etc. So what are some of the reversible causes? And so right off the bat, there's certain drugs out there that can worsen urinary incontinence, and so we really need to have a good inventory of the medications that you're taking. So I just encourage you, when you're seeing your primary care doctor, bring a list, carry a list with you. These are the medications that I take on a regular basis. We can go through them and let you know if any of these are putting you at risk. Sometimes you can't help it, but delirium, urinary tract infections, it's common for a urinary tract infection to become something more sinister, bacteria in the blood. That can cause altered mental status changes, and that can lead to worsening urinary incontinence, not being able to move or get to the bathroom in time. And then I would say impaction. So if your bowels, if you're very irregular, very constipated, that's going to increase number one, your risk of urinary tract infections, and it's going to make it more difficult for you to empty your bladder. And if you're not emptying your bladder, then your bladder is going to fill up very quickly. You're going to have to go to the bathroom more and more frequently. Polyuria is patients that produce a lot more urine than they should. Nocturnal polyuria is producing more urine at night. And one of the most common things that we do see, aside from, let's say, diabetes, is obstructive sleep apnea. So if you snore, then what happens is it really puts pressure on the heart, and the heart secretes a little chemical called ANP, atrial natriuretic peptide. And this chemical, when it circulates at night, actually is like a diuretic or a water pill, and it causes you to actually produce more urine at night. So if you snore, or if your partner says that you stop breathing in the middle of the night, I encourage all patients to talk with their primary care doctor. Do I need a sleep study? Nowadays you can do a sleep study in your own home with some monitoring equipment. They can diagnose, is this mild, moderate, severe sleep apnea, and that may be putting you at risk of nocturnal polyuria. And the definition is, and you can do this all at home, you can record how much urine you're producing during the day. And so you just write it down. You'd need something to collect your urine. Sometimes we give a little hat to say, okay, 200 milliliters or 4 ounces or something. And if you write it down for a 24-hour period, then you calculate how much urine you actually produce at night versus how much you're producing during the day. And if that number is more than 33% of your 24-hour volume is done at night, then we can say probably you have nocturnal polyuria. And there are some medications that you can use to treat that, but it's very important to know what are some of the drugs contributing to urinary incontinence. Alcohol, caffeine, and obviously water pills. And so these are medications that you may not want to take before bed. And so limit the amount of alcohol you may be taking at night. Maybe if you're going to drink caffeine, go switch to decaf earlier in the day. Maybe skip that sort of 3 p.m. coffee. I love it myself. And then, what is the timing of the water pill? This is something that you can ask your primary care doctor. Can I take this one particular drug earlier in the day? I'm getting up 4 or 5 times at night. And then there are certain medications that we use for patients with an overactive bladder, but it can certainly put some patients into urinary retention. So we have to be very cautious about some of the drugs. And then calcium channel blockers. This is a medication for high blood pressure. So just as a little review, this is the bladder. And so we have the bladder, or the detrusor muscle that holds urine, and then this is the external sphincter. And this is under voluntary control. The bladder neck is under involuntary control. And this kind of tightens and relaxes automatically, so it's supposed to relax when your bladder contracts so you can get urine out. But this sphincter, we all have under voluntary control. Obviously, there are some neurologic conditions, let's say if you had a stroke or Parkinson's disease or spinal cord injuries, where you may not have great control of this sphincter muscle, and you may lose it over time. And but I think for the most for the most part, if you're neurologically intact, you have this muscle under control. And we'll talk about how do we use this muscle to kind of help with some of the symptoms. Capacity is probably about 500 to 600 milliliters. And so it's a wide range, let's say 300 to 600, but this is important to know because, if your capacity is only 150 milliliters and you're producing, 450 milliliters at night, mathematically you're going to wake up several times at night. Usually we'll start looking for a bathroom around 300 milliliters. And then, then there's certain points where you can't hold it anymore. That's your maximum capacity. This is tucked in behind the pelvic bone down here, and in females against the anterior wall of the uterus, if you still have a uterus. The area where the urine comes in from the kidneys is called the trigone, and then again we talked about the sphincter. This is a very busy slide, but just know that there's a lot of chemical mediators that lead to bladder contraction, relaxation, sphincter muscle contraction and relaxation. And sometimes these pathways are interrupted for a variety of conditions. We obviously need to know, the medical students need to know which receptors we're working on, what are the different types of drugs, which receptor do they affect, and then if we're using these particular drugs, how are they going to affect you otherwise? Are they going to lead to dry mouth, constipation, delirium? And so this is very important for our trainees and residents and practicing physicians. So as you get a little bit older, your bladder capacity does decrease. And so, I'll have a lot of, men and women, they'll come to me and I wake up, 2 times a night. If you're in between the ages of 70 and 79, it's not uncommon to wake up once or twice a night. Over the age of 80, sometimes up to 3. And that can be considered normal just because our bladder can't hold as much urine. And so if you're waking up a lot at night, make sure you empty your bladder before bed, that you're not taking your medications with a lot of water, because just by nature of getting a little bit older, your capacity will decrease. We don't void as much, so our emptying efficiency is a lot lower, and so we can't empty out sometimes completely. Our flow rates are not as strong, especially as you get a little bit older. You're a guy, you have a larger prostate, flow rates go down. And then we talked about increasing urine production at night. So just to go over in the types of incontinence, there's stress incontinence, urge incontinence, overflow incontinence, and then there's functional incontinence. And functional incontinence means that there is something limiting you from getting to the bathroom. And this is typically mobility. Or it's the middle of the night and you can't see, I can't get to the bathroom, and you don't have any of the other types of incontinence, but just nature of other medical problems may put you at higher risk of not getting to the bathroom. And we'll go over each one of these. So what is stress urinary incontinence? This is the most common in women that have had that have delivered children vaginally. And it's very common, and it's involuntary leakage with effort or exertion, sneezing, coughing, laughing, bingo, and you can't control it. And the sphincter here, over time, gets stretched. It loses that tone, and urine leaks out. And so this is, you can ask somebody, when your bladder is full, do you leak when you cough, sneeze, laugh? Are you lifting up something heavy? And this is relatively easy to diagnose. Again, more common in patients that have delivered vaginally, that have sometimes had their uterus removed, and now they have maybe prolapse. And so there's a variety of treatments for stress incontinence. Number one is sort of tightening up the pelvic tone. So pelvic floor muscle therapy training is really first-line therapy for patients with stress incontinence. And then we go down the line from least invasive to more invasive, and then there's small slings that you can use that act as a backboard to support the urethra, which is very mobile. And then there are some other procedures to get certain organs in place. so that you're not apt to leak. And then, there's other sort of, other surgeries that can be done to, improve stress urinary incontinence. Urge incontinence, this is, very common as you get a little bit older. This is, you're driving down the road, you have the sudden urge to go and you can't control it. Your bladder says, hey, you need to pull over right now because your bladder it's irritable. It doesn't like to hit that capacity. And so this is, again, very, very common, the involuntary leakage accompanied by or immediately preceded by urgency. So are you having the sudden urge to go, and then that's leading to urinary leakage because your bladder will contract, and just by nature of the sort of the neurologic mechanisms, it automatically relaxes the sphincter. And there are treatments, obviously, for urge incontinence. And another term for this is an overactive bladder. Do you have to go, frequently? And it's usually urinary urgency with or without urge incontinence. So you can have an overactive bladder, but be completely dry. So if you still have that sudden urge to go, but you can control it and get to the bathroom, you may not have urge incontinence. And it doesn't happen to everybody. I find that this happens in some guys who have been blocked, their prostate blocks their bladder for a long period of time, and now the bladder has to work harder to get the urine out. And because it works like any muscle, it works harder, the bladder wall becomes thickened, and then the capacity decreases, and then it becomes a lot more irritable. So if an older man comes and tells me that I have a lot of urgency and urge incontinence, it's almost like you've waited too long. The bladder's gone through a lot of changes. That can be hard to recover. And then you could have, a combination of urgency or urge incontinence and stress urinary incontinence. And again, this is, very common. And I would say that, you may be more bothered by the urgency component than, let's say, the stress component. So you may have both, but maybe you don't list up anything heavy. Maybe you don't watch, Seinfeld, and you're not laughing. And so maybe you're not bothered by the stress, but you're maybe bothered by the urge. So really important to, think about your day-to-day. When are you having these leakage episodes? What are you doing at the time? And just so that you can communicate that well to your, treating urologist. Because you may not need, surgery for stress incontinence, but maybe you need some treatment for the urge incontinence. And then there's overflow incontinence. So this is very similar to urgency, but this happens a lot of times with certain medications where your bladder is not able to empty, and it gets very thick, very full, and then you're actually leaking a little bit because your bladder is too full, and it gets to the point where your bladder, if it's so full, it can automatically spasm, just like somebody with an overactive bladder, and it can kind of spasm and urine leaks out. And so the first test that we like to do is what we call a PVR, a post-void residual. So you urinate, and your residual should be 0. So you should be able to get everything out. But if your residual's 400 or 500, you're probably in retention, and your leaking is probably from this. I usually see guys that come to me and they have an overactive bladder, but really they're actually in retention. And then we have to treat what is the underlying reason for the blockage. And I would also say that there are a lot of patients that have spinal cord injury, that their sphincter is heightened tone throughout the day, and that's one of the reasons why they can't get the urine out. And so there's certain conditions like MS and spinal cord injury, Parkinson's, Scheidegger's, that can wreak havoc on the urinary system. So first thing, are you emptying okay? Are you able to store urine at a safe pressure? Because if you're not, if the bladder is like a lead pipe, it puts pressure on the kidneys and can cause kidney failure. And so we really want to know, anyone who has like a neurologic condition and any urinary symptoms should really see a urologist to make sure that we're emptying quite well. and we oftentimes will recommend a urodynamics. And then we talked about this, so functional incontinence, maybe you can't see, get to the bathroom, immobility, you can't communicate to your care providers. Let's say you're bedbound or you've had a stroke and you have aphasia, and you can't let them know, hey, I need to go to the bathroom. This is all sort of functional incontinence. So how do we evaluate patients? Usually patients will come to us with a history. We'll assess what medications are you on, what can we do to reverse some of the kind of situational factors that may be leading to urgent incontinence. If it's persistent, what's the type? How do we initiate? And then we initiate treatment. This is mainly for the primary care doctors. So they're sort of your first line. Hey, this is a significant problem. Should I be referred to a urologist? So you're going to be the best advocates for yourself to see a specialist. And so we take a really detailed history. I think in order to maximize your initial visit, keep track of a avoiding diary. I love patients that come and especially the engineers, they come with the time that they've urinated. So all you really need to do is, these are the times that I avoided during the day. This is my fluid intake, and this is my urine output. You may not have something to collect the urine output. And this area, this time is really most bothersome to me. And I like to use this sort of online website called WellPrep. So if I see someone coming in with a certain condition, I text them the link, and they go on to the page, and then they can find the reason for their visit. And then there's a lot of different information that they can get beforehand. So they come to the office visit, and you're maximizing your time with the specialist. We do a physical exam. Where are you tender? Are you tender here over your bladder? What about the kidneys? Doing a good pelvic exam. If you have recurrent urinary tract infections, do you have a lot of vaginal or urethral atrophy? Is the urethra hypermobile? Is the bladder falling? Is the rectum coming out? Is the vagina falling out? What is the support structures? We do a rectal exam. What's the tone? Do you have a lot of stool in the vault? So a lot of things that we can get from the physical exam. And then some of the tests that we do is we just, provocative measures. We make sure that your bladder has something in it, that we can ask you to cough and see, do you leak? Because that intra-abdominal pressure, if you have stress incontinence, you won't be able to control it. And you may have a hypermobile urethra, and then you leak. This one's key, again, the post-void residual, and that's really, you really need a small little ultrasound, quick thing to do. And they put a little ultrasound over your bladder, press a button, they can tell you how much is left after you've urinated. Urinalysis is pretty basic, and we can look, is it nitrate positive, leukocyte positive, any risk of urinary tract infection, and then are you spilling a lot of glucose? And so there's a lot of patients being treated now with a lot of these medications that are causing you to get rid of the sugar, but it's getting rid of the sugar in your urine, and that has been predisposing a lot of patients to urinary tract infections. So if you're getting started on these diabetic medications, hey, will this increase my risk of urinary tract infections? And then see what your primary care doctor says. And we can also see it on the urinalysis. Oh, you're spilling out a ton of protein, or you're spilling out a ton of sugar, and that's very important for us to know. And then I think sort of a secondary test is the measure of the kidney function. Is your kidney function normal? There's something called urodynamics. You may be familiar with it, but this is a in-office test that your urologist may recommend. It's a test that really only we do as specialists, but it gives us the most information, and it's usually done on a visit alone. Probably takes about 30 minutes or so throughout the entire appointment, but it gives us the most information to really figure out the type of incontinence that you have. Not everybody needs this because it's pretty simple based on a good history, but we may recommend this additional test down the road. Sometimes when we're kind of going through the algorithm of treatment, insurance may recommend this particular test. So urodynamics, how it's done, is we put a little catheter in your bladder to drain your bladder. We want to know how much residual you have left over. The ultrasound is good. It's not perfect. It's putting the catheter inside the bladder through the urethra, emptying your bladder completely. Oh, you have 1 or 2 ounces of urine left over. And then through this catheter, we can fill up the bladder. We do it slowly, 1 or 2 ounces a minute. And then we're going to ask you some questions. Okay, well, when would you think about going to the bathroom? Oh, when would you start knocking on the door of the bathroom? Oh, when is the maximum capacity? So what is the, how good is your sensation? Is the sensation intact? And what is your, capacity? We may stop the test maybe at about 100 milliliters and ask you to cough. So if you come in with stress incontinence, we'll say, okay, now I want you to hold your urine and cough and see if anything leaks out. So we want to know at sort of what bladder volume you may have. There's also a catheter in the rectum that measures the intra-abdominal pressure. So what is going on with the bladder? What is going on with the abdomen? And we get the bladder pressure really by subtracting the abdominal pressure, which is a little rectal catheter, and the one in your bladder to get the detrusor pressure. And so we can see exactly what is going on with the bladder in real time. And so you may come in with an overactive bladder, and as we're filling you up, we see the markings on for the detrusor, because it's a subtracted number, go very hyperactive. Okay, that's a contraction. And then if you say, okay, well, yes, I'm having a contraction now, then we can kind of correlate that with what's on the test. And then we also measure the compliance, so how safely are you storing urine? It really should be like a balloon. We fill it up, the wall becomes thin. It shouldn't really be like that lead pipe. And then at the end of the test, so there's a filling phase and then there's an emptying phase. When you reach that capacity, I can't hold anymore, we say, okay, we'll go. And just empty your bladder. Usually you're kind of sitting down and there's a funnel underneath you and you just urinate. Then we can see, is the bladder contraction working? How much squeeze do you have? In men, is it very, very strong contraction? So if you have a very strong contraction and a very low flow, we can say, oh, you're probably obstructed. And what is that bladder pressure? And is your sphincter doing what it's supposed to do? Because your sphincter should relax when your bladder is contracting. So if your bladder contracts and your sphincter relaxes, that's everything working in unison. But in spinal cord patients, we do often see detrusor sphincter dysynergia. So they're not working together. So your bladder could squeeze and the pelvic floor tightens up. Now you can't empty. And that really wreaks havoc on the kidneys and put you in kidney failure. So this is a great test for us. Sometimes it's done with x-rays, usually not, but it's slightly invasive, but it gives us the most information with which to tailor your care moving forward. Usually when you get bladder cancer in your 40s, there's either an environmental problem or it's a genetic problem. And nowadays we are testing more and more for genetic, different genes that may predispose you to breast cancer, prostate cancer, kidney cancer, bladder cancer. So if I had that particular history of family dying at an early age or being diagnosed, then certainly that would tip me off that maybe there's a genetic syndrome. And there's certain conditions like Lynch syndrome where you may have a higher risk of colon cancer, bladder cancer, kidney cancer, et cetera. That's a very good question. So what are the treatment options for patients with urge incontinence? These can be behavioral, pharmacological, and other sort of more invasive surgeries. A lot of studies have been shown that behavioral therapy works great. It's very effective and it's useful for both stress and urge incontinence. They don't necessarily cure you, but they can ameliorate some of the symptoms and that you may be experiencing. And they're both effective in men and women, and it's really best for patients that are cognitively intact, someone who's motivated to get dry. And you can do this by yourself. I always advocate for you to see a physical therapist, and now we have physical therapists in Needham, especially downtown, that just specialize in pelvic floor physical therapy, teaching you the techniques that you need to get you dry. Other things that you can do is timed and scheduled voiding. I saw a lot of young guys recently that came to me, I'm waking up and I'm wet. I'm having what's called nocturnal enuresis. And during the day they're fine, but at night they can't control it for whatever reason. They're deep sleepers. They may have an overactive bladder. So one of the treatment strategies to get you at least dry is set an alarm. Set an alarm. If you're waking up at 2 a.m. every single night and you're leaking, you may want to set an alarm for 1 o'clock and make sure your bladder is empty. So that's a treatment strategy. Make sure you get to the bathroom and empty your bladder before you have that sudden urge to go. My capacity is 300, then you need to get to the bathroom at 200 or 300 or less so that you're not suffering. And sometimes that's a little watch, a little alarm, but just you want to do timed or scheduled voiding, and sometimes even double voiding. I know I don't empty my bladder for whatever reason. A lot of men and women, they if they're out in public, they may not sit down on the toilet. And just by hovering over the toilet, you're not relaxing your pelvic floor, and so you may not be able to empty your bladder completely. So you have to make sure that you relax, empty your bladder, and then wait a few minutes, and then empty your bladder again. So these are some of the behavioral things that you can do. Pelvic floor muscle exercises. So what I tell my patients is your bladder is full, you have to go to the bathroom, and you want to prevent yourself, or you want to tighten up your pelvic floor. So if you wanted to stop yourself midstream, that's the muscle that you need to practice and get stronger. And this again is under voluntary control. We can all do this. You're sitting there, you're listening to like a boring lecture on incontinence, and you're tightening your pelvic floor muscles. And what you do is you just tighten it, hold it for 5 to 10 seconds, and then relax. So you see a commercial come up, you try to do that maybe 3 times during the commercial break. And that alone will tighten the pelvic floor. And this also inhibits the urge. So maybe you have to go to the bathroom now, I have a lot of urgency, let me tighten up the floor. This is called quick flicks. And so you tighten, relax, and that will ease some of the overactivity, the instability of the bladder, and it works. That's called quick flicks. And you can get to a physical therapist who teach this very well rather than us. We don't sometimes have a lot of time in the office. You may want to reduce your intake either during the day or at night. You don't want to drink too much before bedtime, and then really avoid some of the other things before bed. So time voiding, this may sort of work with your schedule, and then you can actually increase your bladder capacity by doing the pelvic floor muscle exercises, inhibiting the urge, and then see, every day, can I get from 2 hours to maybe 2.5, maybe 3 hours. Maybe 3 hours is enough, but maybe you want to increase by 30 minutes each week until you can hold your urine for up to 4 hours. And then the one thing that the physical therapists have is they have feedback. So they can put a little sensor right where your sphincter is, and they can tell you on the screen, oh, you're doing it perfectly, or you need a little bit of work. And it's nice because you get the feedback, and that can really help you moving forward. If you've tried the behavioral strategy, is still not working, the mainstay of therapy is anticholinergic. They've tried some medications to tighten up the pelvic floor. That doesn't work. Estrogen doesn't really work. But I would say the mainstay of therapy are these medications. You may hear of them: Detrol, oxybutynin, Sanctura, Enablex. So there's probably about 10 different medications. They all have different side effect profiles. Really first-line therapy. They're anticholinergics, usually daily medications or twice daily. I would say that in patients over the age of 65, we have to be very cautious because these medications can cause actually delirium. It can cause you to hold on to your urine. The safest one is this one, Sanctura. It's a quaternary amine. It does not cross the blood-brain barrier, so that's probably the only one safe in the elderly. That one, and there's probably another one called Toviez that has a lot of data on it in the medically complex elderly patient that I would sort of reach for. There's some of these can interact with some of your other medications. In those patients who may not be able to tolerate the anticholinergics, and usually we try one, you have to try it for about 4 to 6 weeks. You can't say it didn't work after about 3 days, so you have to be consistent. about 4 to 6 weeks to say it didn't work. If that didn't work, then we may switch you to maybe a newer agent. Usually insurance requires you to have a trial of 2 of these medications before they will cover additional therapies down the road. This is great. This is probably the newest ones in the class. They're called beta-3 agonists. And if you remember that picture of the nerves, if you stimulate the beta-3 receptor, then that will relax. That will inhibit the urgency, the urge incontinence. The newer one is Vibegrón, but Mirabegron or Myrbetriq is one of the names that you may hear. It's given in 2 doses, 25 and 50. I usually start with the 50. Very well tolerated. It doesn't have the side effects that the other ones do. Sometimes it can increase the blood pressure a little bit, but very well tolerated. You can use these in combination. So if you have really bad, urge incontinence, sometimes we'll pick one here, take them both together. That may work. The side effects of the anticholinergics, dry mouth, constipation, so you have to be very cautious, really make sure your bowels are regular. And the goal is to have a very soft, long tube of poop. And I remember my attending, Anne Gormley, probably one of the most sort of famous female urology experts in the world. She would show the chart and, where is your poop? And there's like different categories, and she was very adamant that you needed to have this, very soft, long tube of poop. She's actually the only female that was inducted into the GU surgeons. And it's really remarkable, and this was only a couple years ago. One woman inducted into this very well, prominent urology. You have to be invited to be a member of GU surgeons. Dr. Babayan was a member. So I think there's a lot of data to show that these medications plus behavioral fat strategy works very well. So everything is better in combination. We have to change our behaviors, maybe lose some weight. We can't really affect how old we are, but can you combine pelvic floor physical therapy with maybe biofeedback and one of these drugs? There's certain contraindications, patients that we don't use these medications on. If you have delayed emptying, some of the newer drugs like Ozempic, semaglutide, this can affect gastric emptying, so you have to be cautious. Narrow angle glaucoma, so make sure you talk with your ophthalmologist, do I have this or not? Bladder outlet obstruction, so very large prostate, some cardiac arrhythmias. And then if we've sort of exhausted the medical therapy route, then it kind of opens up an opportunity for some of the I would say more procedural-based treatments for an overactive bladder. So this is primarily for overactive bladder, urge incontinence. So you may have heard of Botox. Some people inject it into their brow. They want to look younger. We can inject it into the bladder. This is done in the office. And so you can actually take the botulinum toxin, which is a paralytic, muscle paralytic, and you can inject it into probably about 20 different areas in the bladder. And it's a small little amount. It will paralyze the muscle of the bladder up to 9 months. So usually it's about 6 to 9 months that it's effective. But this works probably better than medications. And I would say it's a minor procedure, small risk of bleeding, small risk of infection, very minor risk, but works extremely well to increase your capacity. So if you have, let's say you can't tolerate any of the medications, you come into the office, maybe twice a year, and you get your Botox injections, your bladder looks very relaxed, it looks a lot younger, and very well tolerated. Some insurances will pay for it, but again, you have to really go through the trials of other medical therapy, but this works very well. We have a couple of partners that do this consistently. If you've seen a Urogyne, they do this quite a bit, but really remarkable, very safe. I would say that if you're going to go this route, sometimes it works so well that it puts you into retention, that you can't pee, I can't empty my bladder anymore. Ooh. In that situation, you have to actually pass a catheter yourself. And so we wouldn't do this if you're not willing to pass a catheter yourself, a tiny little catheter into the bladder, to empty it. Because sometimes it works so well, it'll relax, and you really need to get your bladder empty most people are in retention for just a few days. They catheterize for a few days, but you have to be willing to pass a catheter yourself. We counsel patients, you have to be willing to do it, and most of the time it works. Sometimes you have it a little bit longer than you'd like. But yeah, we have a lot of patients that have to do clean intermittent catheterization. You have a big prostate, bladder, neck stenosis, you pass a catheter, and it's amazing. Some of the patients that have to do it, patients with neurologic conditions, sometimes they have to empty their bladder because they can't otherwise. But we call it clean intermittent catheterization. It's a treatment strategy for select patients, sometimes in the short term. Another one that's maybe a little less invasive is peripheral tibial nerve stimulation, or PTNS. And this, you take a little needle and you put it just in the tibial nerve in the foot. And what it does is it really kind of inhibits a lot of the nerve impulses to the bladder. And so this works. I would say it really does require a time commitment of you, so you have to be willing to come into the office, spend about 30 minutes there, sitting to a chair connected to this unit for up to about 12 weeks. And sometimes there's maintenance involved, where you may come back every 3 months if you're doing well. But this is something that's really non-pharmacologic, that's not really surgery, that's very safe, that works for a lot of patients, PTNS. And so you just have to sort of be willing to kind of make the trip. And then there's sacral neuromodulation. Very similar concept. Can we inhibit some of the impulses that may lead to an overactive bladder? And usually there's two parts to this. One, they just put some external leads in the sacral roots, S3, S4, and then you go home with this, a generator like this, and then what they can do is they can adjust certain, pulses or impulses to really inhibit the amount of overactivity that you have. If it works, then you would need a smaller sort of implant, tucked in underneath the skin, and I'll show you that. So this is somebody enjoying, PTNS, and so it looks very relaxed. You can read a book or do whatever. But this is the sacral neuromodulation, or InterStim is another one. They've made this unit a lot smaller. This does require a trip to the operating room, if it works, to really implant this generator in a subcutaneous pocket. It has a life expectancy, but nowadays it's relatively small, MRI compatible. It can be a small risk of bleeding or infection, but it's slightly invasive, and we use it in very severe cases. But again, if you've sort of exhausted all the other lines of therapy, this may be a very good option. About 33% will require surgical revision. In randomized controlled trials, 50% are cured after about 8 weeks. And there's not many things that cure you, but this can significantly help. And they've done these studies where they've almost done the placebo, a sham control trial. And very difficult to enroll, because as a patient, you're going to be enrolled to having a procedure or not. But these studies are very robust and get level 1 evidence. So this certainly does work. 50 to 75% symptomatic improvement in short-term studies. And then 76%, so 3/4 of the patients are significantly improved at 18 months, or at least up to 18 months. Sometimes these studies don't go much longer than that. And then this is a urologist putting the botulinum toxin inside the bladder in a variety of different areas. We actually use this a lot in patients that have spinal cord injury. And so they're refractory to the medications. They have a very thick bladder wall. They have detrusor sphincter dyssynergia. Kidneys are at risk. A lot of patients will actually need this Botox every 6 months. So in summary, behavioral treatment is effective for treating both stress and urge incontinence. Drugs are the mainstay of therapy for an overactive bladder. and they're effective in treating urgency, overactive bladder, but you really need to caution, in patients that are a little bit older. You have to make sure that you know what other drugs they're taking, what other medical problems they have in our patients. You don't want your urine to be too concentrated, so one of the easy kind of ways is, what does my urine look like? Is it yellow? Is it super concentrated? You're not drinking enough water. You want it sort of very light yellow. And that's probably sometimes even better than, I need 48 ounces. What is my urine looking like when it's in the toilet? Does it have a very strong odor? Is it super, concentrated? Then I would say you're not drinking enough water. But I think a good rule of thumb is probably about, probably about 6 to 8 of those kind of, 8-ounce bottles a day. But obviously you don't want to, drink too much if your issue is that you're leaking all the time. But sometimes an overactive bladder is from somebody, they don't want to drink a lot. And they think, okay, well, if I'm drinking not enough, I'm not going to, go. That's true, but then having very concentrated urine is very caustic to the bladder. It's very irritable, and that can worsen the overactivity. So spicy foods, caffeine, not drinking enough, that can also lead to an overactive bladder. You hit the nail on the head, exercise. So guys come to me, I have erectile dysfunction. 30 minutes, 3 times a week, cardiovascular exercise is better than Viagra alone in a recent study that was published. And so patients, if your BMI is up there, losing weight will actually help your stress incontinence, help your prostate, help the urge incontinence. And so maybe you need some help with some of these medications that are really phenomenal, semaglutide, to lose some of the weight, because some of these other conditions will get a lot better. Okay. Well, thank you very much for the invite. It's great. You guys had great questions, and thank you so much.